Hello everyone, welcome back to another session of Beyond Teeth, Wine, and Learn. This study club is meant to bring all the aspects of clinical and non-clinical topics on one platform. If you are interested in joining our sessions, we meet once a month. You can always send me an email. I will add you to to all the mass email group, and when we are organizing, you will get the registration link for any topic that you want to be discussed, and for any kind of questions or doubts related to anything in dentistry, you can always send me an email or post on the group, and I'll be happy to solve your question. If I cannot, then always we have a team of other specialists, other dentists who will try to respond. And that's the whole point of our club, the study club of Beyond Teeth, Wine, and Learn. Well, I'm going to start today's session, and that is on crown lengthening and its application in restorative dentistry. So, the presentation roadmap, how we are going to go about is there will be clinical scenarios and problems that we are going to discuss. I'm going to show you and get your idea on how would you have treated this case. Then understanding biologic width, it's a really important concept, and if you've understood this concept, there is no way you will not be able to apply the principles of crown lengthening. And then we'll have a case discussion. Okay, so let's start with this first case. And well, let me show you this picture, this x-ray first. If a patient, let me turn on my pointer here. If patient comes to you with this broken tooth, what are you going to do? Well, let's say patient A, she had come to me, she's in her 40s, she had come to the clinic and she was very distressed and upset because another dentist that she had gone to was telling her that the prognosis is really bad, anyway we cannot save the tooth, and she was given an estimate for the implant. Okay, now let me go back and show you what I did. I did restore this. Okay, but if this patient would have come to you, what would you have done, and why you would have done what ever the treatment planning in this case would be: extraction or restoration? Similarly, there's another case. This case I had posted on my Instagram. If you don't follow me on Instagram, the Instagram link will be in the end of the video. So if this patient comes to you, this patient had a crown that was done like probably a few months before, and now the patient presents with this kind of a situation. You know how the root is. The tooth is partly broken. There is a post which the dentist had put in before, trying to see if they can actually do a post and core, but the crown did not stay. What are you going to do? And what are the factors that will make you decide as to you are going to save the tooth or not? Most commonly, the factors that we are looking or considering when we have to save a tooth are, we are looking at the crown root ratio, we are looking at if the tooth is mobile, and even if we try to save the tooth, how much of it will be there for considering a crown, right? So these are the most common factor, restorative factor as well as your periodontal factors that you are considering. Now, I will be coming to the discussion of those cases that we have shown you, but I really want you to start thinking about this particular issue. Now, let's see here. Now, you have a patient who has come to you with this broken restoration. Now, all you can see is there's a lot of gingival overgrowth there, and it's not that easy to, from this picture at least, yeah, when clinically you see the patient, yeah, you can probe and see, okay, where is the restorative margin or the decay, but when you see so much gingival inflammation, there is slight inflammation, but the margins of the tooth is below the fracture line, then how will you decide? Here, the x-ray, you can see this is not a really great bite ring, but yes, you can see the bone is, if the bone is somewhere here, this is the margin of the tooth. And in this picture also you can see, let me show here with a pen, that this is where the decay is, and the tooth somewhere here, and this is the bone. So we do know that the margin of this particular tooth or the break is below the gum in this scenario. Okay, so again, how are you going to do this in case? Okay, how are you going to do? Are you going to just go ahead, remove the decay and restore it, or are you planning to do something with the gums here? And why should you? Why cannot you do a restoration sub G? We are going to discuss all these points in this presentation. A very important thing that I want you to think is this kind of cases that are very common. You know, this was a 40-year-old female. She came and the crowns were done by a previous dentist, and now she's complaining that her gums are very inflamed. Well, this picture is not an exact picture. I took it from Google Images, but I had a similar case. The picture was really blurred, so I did not put here. But yes, in this kind of scenario, why do you this is happening? A 45-year-old female and inflamed gums, and this happened after the crowns are done. Well, some people would say maybe she's not brushing well. The hygiene is not good. The margins are sub G, and that's causing the problem. But is that all? That could be a reason, but is that all? Or is there a bigger picture of biologic width violation? Most commonly in sub G areas where the patient is complaining of inflammation in the gums, when you are having issues of severe pain after the crown, most common reason is biologic width violation. So let me discuss here what is biologic width. Now, biologic width by definition is, or also the new term is supracrestal attachment. That biologic width is the dimension of the soft tissue which is attached to the portion of the tooth coronal to the crest of the alveolar bone. Now, sometimes it is difficult for people to understand what exactly it is because it is something to you're just looking at the definition. So I have two diagrams here. This is your tooth. This is the bone, and above this you have this pink gums, right? So basically this area where you have your tooth, okay, your CEJ, the area that is comprised of your sulcus, okay, and then you have your junctional epithelium and connective tissue attachment. So to translate this into this particular diagram, you can see if this is the tooth and here is the bone, then the distance between when you are probing. So this distance between your bone, then you have the epithelium, you have the sulcular epithelium, the sulcus, right? The sulcus and your connective tissue where your fibers are attached. That distance is your biologic width or supracrestal attachment. Okay, so how would you determine in a very regular pattern is, let me go back to this diagram, that is if you have a looking literally from the front, that this is your tooth and then bone obviously you cannot see but you can feel it. So from your free gingival margin from the CEJ, or let's see from the free gingival margin, when you probe the distance from there, that is like that includes the sulcus. So here this is your tooth. The distance from here till the bone should be 3 millimeters and you cannot violate that area. Just let's keep it that way just for a basic understanding if something else is not really easy to understand. And there I'm quoting some articles here, there is general agreement that placing restorative margins within this biologic width in this area. So imagine if you're doing a, let's have a pointer here. So imagine if there is a crown that is coming in this area, the margin of the crown is coming here, that is basically we are talking about is biologic width. Okay, erase it. And so leads to gingival inflammation, attachment loss, and bone loss. This is because of the destructive inflammatory response to microbial plaque, which is located deeply placed restorative margins. So that's what happens, and that is what we were showing in the picture before, that when you place the crowns of the margins of the crowns which are placed sub G, or even your restorations which are really placed sub G, and there is no the distance between your margin of the restoration of the crown and the bone is less than 3 millimeters, that means you violated the area where the epithelium, the connective tissues were supposed to be there, and now that area because of the plaque and everything, there is inflammatory reaction happening. Same thing, this is another study, I'm not reading it, but again, the same study, the similar pattern of studies that say that if you place, like in this, the author had class of cavities were prepared. So they were comparing the class of cavities where the cavities were prepared. So the apical border rested on the alveolar crust, and in one, the notches were placed at the CEJ, and then they were restored with amalgam. So the teeth in which the margins of the amalgam were placed at the alveolar crust, like they went closer, those cases had more gingival recession and bone loss. Okay, these pictures I've taken from a book from the Atlas of Periodontal Surgery, Cohen, and a few are from different articles also. So let's see this kind of scenario. Very common in our practices, you'll get a tooth like this, and this is the x-ray. Now you look at this and you're like, how I'm going to restore? Well, some people will definitely, some dentists are going to restore it, and the margin of the crown is going to be something like this. But you see what's happening here? This is your bone and this is the CEJ. I mean, this is the margin of your crown, and you are definitely violating the biologic width in this scenario. So like I said, we cannot we don't want to violate this area, because now we've understood that violating is going to cause the issue of gingival recession and bone destruction. So a minimum of 3 millimeters has to be there. Okay, otherwise you will have greater chance of bleeding and gingival recession. So ideally what we should do is crown lengthening. Like you see, they rose the flap is raised here. They cut the bone, they did the osseous contouring, put the flap back, give the crown, and this is ideally what it should be. You see the distance here, it is almost 2 millimeters, 2 to 3 millimeter, but this is how you should be approaching the case. You always have to first do a transgingival probing. Sometimes you can easily make out from the x-ray also. Now, similar thing, very common to have these kind of cases. Now you see this patient has a thick biotype. This is not really contoured. I mean, the margins are not really nice. And we are thinking about aesthetic crown lengthening here. Again, the first step will be your assessment as to will you need to do some kind of a bone reduction here or no. So you will go by the different classifications. Do you need orthodontic intrusion? Do you need crown lengthening? Okay, and let's go by, and another is gingivectomy. So these, one is ortho, one is crown lengthening, which is basically like, will you do any reduction of the bone or no? And one is gingivectomy, where you do not require any bone contouring. What is the criteria? So there is a classification by Garber and Salama, where you have this whole criteria of when to decide when you need gingivectomy only. So if you have 2 to 3 millimeters distance between osseous and CEJ, adequate amount of attached gingiva, only gingivectomy. If the osseous crest at CEJ, then obviously, like I said, you need a distance osseous surgery. If the osseous crest is 2 to 3 millimeter apical to the CEJ, inadequate attached gingiva, so to increase the width, apically position flap. And again, different story of APF and osseous surgery. And then also provided is a chart where you would make a decision of do you need crown lengthening, which we were discussing before. If you have a deep pocket depth of more than 4 millimeters, you always do crown lengthening. Okay, but this is under all come in a scenario that the gingival display is less than 8 millimeter. If the gingival display is more than 8 millimeter, we go with orthognathic surgery. And again, same thing that we were discussing, when to do gingivectomy, when to do flap, when to do APF. So what we did in this case was, again, this is not my case, but this is a picture from the book. You raise the flap, measure the distance, put the flap back, and you see the picture. And like I said, clinical scenarios which I will be showing. So the case in which this was supposed to be deemed by another dentist to be non-restorable, I ended up doing the root canal. I restored it, ended up doing the crown lengthening. You can see how I'm doing, contouring like positive architecture here. And this is the case that we ended up doing. You see crowns, and you see you have a 3 millimeter distance between the margin and the alveolar crest. The other case that I had shown you here So I do not want to place the margins of the restoration below the CJ. I ended up doing just gingivectomy because the margins were fine, and we restored it